Welcome to the Deep Dive. Today we're getting into the weeds of the 2015 NHG guidelines on pressure ulcers, or decubitus. We're pulling out the essential knowledge you need.
Exactly. These guidelines, they've really shifted things. Our goal here is to give you that clinical shortcut, focus on what's absolutely critical now for managing these wounds, and, importantly, what we need to stop doing.
Always good to know what to stop.
Yeah.
So let's start with the basics. Decubitus. It's that localized damaged skin or deeper tissue from pressure, right? Usually over bones, like the tailbone or heel.
That's it. And the fundamental problem underneath is ischemia.
Ischemia, lack of blood flow.
Right. The pressure is just too high or it lasts too long and it squeezes those tiny blood vessels shut. No blood, no oxygen, and the tissue, well, it starts to break down. It dies. Simple as that, really.
But it's not just simple pressure, is it? The guidelines talk a lot about this other factor, this damage multiplier, shear forces.
Oh, absolutely crucial. Shear is, well, imagine your patient is sort of slumped in bed, okay? Gravity pulls their bones down, but their skin gets stuck on the sheets.
Like trying to pull a rug out from under furniture.
Exactly, that kind of internal stretching. The skeleton moves, the skin stays put, and that force just tears the small blood vessels anchoring the skin to the deeper tissue. It's often worse than direct pressure for causing deep damage.
Okay, so understanding that pressure plus shear dynamic is key for prevention.
Got it. That's the foundation for pretty much all the preventative advice in the 2015 standard.
So now we know the mechanism. Let's talk risk. Who are we most worried about? It's just very sick people?
Well, it can happen at any age, but honestly, it's overwhelmingly an issue for older adults. The guidelines say the risk really climbs after 65 and jumps sharply again after 75.
And the hot spots are usually the buttocks, the sacrum, and the heels.
Those are the most common sites, yeah.
Okay, so the biggest risk factor is being bedridden or stuck in a wheelchair, especially if you rely on others to move you. What about other factors we can maybe control?
Nutrition. It's huge. The guidelines actually set some pretty high targets to keep tissue healthy or help it heal.
How high are we talking?
We're talking 30 to 35 kilocalories per kilogram of body weight each day. And protein needs are up there too, about 1.25 to 1.5 grams per kilogram daily. Plus, fluids around 1.5 to 2 liters a day.
Wow, that sounds like quite a challenge for someone who's elderly and perhaps not feeling well or eating much to begin with.
It really is. It takes dedicated nutritional support. And then you've got other factors like, poor circulation, diabetes, even just having really dry skin can make things worse.
Right.
But there's one risk multiplier that the sources really highlight: incontinence, specifically combined urine and feces.
Yeah, I can see how the constant moisture and friction would be bad, but how much worse does it make it?
The guidelines actually state it increases the risk fivefold. 5 times.
Oh, times, wow.
Yeah. The skin gets macerated, weakened by the wetness, and then the friction from moving on soiled sheets. It just makes it incredibly fragile and susceptible to breakdown from pressure and shear.
Okay, that really underscores the need for meticulous skin care for incontinent patients. So before we get to prevention, let's quickly touch on the categories. The guidelines say category, not stage or grade, right?
That's right, category 1 to 5. It avoids implying that they always progress neatly from one to the next, which they don't.
So category UN is that persistent redness that doesn't blanch when you press it. Skin's intact.
Correct. Category 2, you've got some skin loss, maybe like a shallow ulcer or a blister.
Okay.
Category 3 is full thickness skin loss. You can see the subcutaneous fat. And category 4 is the deepest, where you might see exposed bone, tendon, or muscle.
Now here's something really important. The guidelines point out a potential blind spot for clinicians. Identifying category 1, that redness, in people with darker skin tones.
Yes, this is a major point. That classic sign, non-blanchable redness, it's just much harder to see, sometimes impossible, on darker skin.
Which means diagnosis gets delayed.
Exactly. And that delay in starting preventative measures means these patients are, unfortunately, disproportionately represented in the more severe categories, like 3 and 4.
So if you can't reliably see the redness, what should clinicians be looking for instead?
You have to use other clues. Feel for localized warmth compared to the surrounding skin. Check for any hardening, what we call induration, or maybe some swelling, edema. You need to be more vigilant with your assessment.
Right. Rely on touch and comparison. So the message is clear. Prevention starts immediately when someone loses mobility. Let's talk strategy number 1, positioning.
Absolutely fundamental. Regular turns are key. The guidelines say at least every 2 hours if sitting and at least every 4 hours if lying down. but it's how you position them that's changed.
This is where the famous 30-degree side-lying position comes in, right? Why 30 degrees? Why not turn them fully onto their side, 90 degrees?
Because that 90-degree position is actually harmful. It puts intense, direct pressure right on the bony bit of the hip, the trochanter, and the shoulder. The 30-degree tilt, just gently rolling them onto their side, supported by pillows, shifts the weight off those pressure points onto more fleshy areas. You alternate, 30 degrees right, then back, then 30 degrees left.
Makes sense. And what about sitting up in bed? Lots of patients end up kind of slumped halfway up.
Yeah, that half-sitting position. It's terrible for shear forces on the sacrum. The guidelines explicitly say avoid it.
So what's the alternative if they need to be elevated?
Use the semi-Fowler position. That means raising the head of the bed and the foot of the bed, both to about 30 degrees. This helps keep them from sliding down and creating that shear.
Got it. And if they're up in a chair?
Limit the sitting time max 2 hours continuously. And crucially, make sure their feet are properly supported, flat on the floor or on footrests. This takes some pressure off the sitting bones, the ischial tuberosities.
Okay, position is job one. What about equipment? Support surfaces? Cushions.
Right. Anti-decubitus mattresses and cushions are essential. They work by increasing the surface area the body is in contact with, spreading the pressure out.
There are different types, static and dynamic.
Yep. Static ones just distribute pressure constantly, like special foam or gel. Dynamic ones have air cells that inflate and deflate alternately to shift pressure points. The guidelines actually say there's no definitive proof. One type is universally better than the other. Often it comes down to practicalities and patient need.
But there is one very specific measure the guidelines emphasize, especially for the heels.
Yeah.
Talk about floating heels.
Yes. This is so important and often missed. Heels are incredibly vulnerable. You need to place pillows or foam supports under the calves, making sure the knee is slightly bent so that the heels are completely lifted off the bed. They should be floating with no pressure at all.
Totally suspended.
Totally suspended.
And while we're on cushions, there's a big warning, isn't there, about those ring or donut-shaped cushions.
Oh, absolutely. Avoid them. Please avoid them.
They seem like they'd work, taking pressure off the middle.
Logically, maybe, but they actually concentrate pressure on the area resting on the ring. This can cut off circulation right there and cause tissue damage. They can literally create pressure ulcers, so no donuts.
Okay, message received, no donuts. Let's move to skin care. For dry skin, use Greethy creams, applied gently. And now for that myth buster. What about massage? People used to massage red areas, thinking it helps circulation.
Yeah, that's a big one. The 2015 guidelines are very clear. Do not massage areas at risk or showing redness.
Why not?
There's simply no good evidence it helps prevent pressure ulcers. And worse, vigorous rubbing or massage on already fragile skin or over bony areas where the tissue might already be compromised underneath could actually cause more damage. So it's actively discouraged.
Okay, no massage. Gentle cream application only. And for incontinence, besides changing frequently, barrier creams are recommended, like zinc oxide.
Yes, barrier products are crucial to protect the skin from that constant moisture and irritation, trying to mitigate that 5-fold risk increase we talked about.
So once a wound actually develops, all this prevention continues, but now we need to manage the wound itself. Diagnosis is usually obvious, but assessment is where things get sophisticated.
Right, and this is where the time model comes in as the standard framework, especially for those more complex Category 3 and 4 wounds. It's way more informative than just saying a wound is black or yellow or red.
Okay, let's break down time. T stands for?
Tissue. What kind of tissue is in the wound bed? Is it necrotic dead tissue, which looks like black, hard Escher or softer yellow slaw? Or is it healthy red granulation tissue? This tells you immediately if debridement, cleaning out the dead stuff, is needed.
Makes sense. I is for?
Infection or inflammation. Are there signs of infection? We look for things like increased redness spreading around the wound, more pain, warmth, maybe the bad smell, or a sudden increase in wound drainage, the exudate.
Okay, that guides whether you need to intensify cleaning or think about antibiotics.
Moisture. This is about balance. Is the wound too dry, which can stall healing? Or is it too wet, weeping lots of exudate, which can damage the surrounding skin maceration? This M is the main factor that dictates your dressing choice.
Got it. And finally, E.
Edge. What are the wound edges doing? Are they advancing inwards, showing signs of healing, or are they stuck, maybe rolled under or unhealthy looking? The edge tells you if the overall wound environment is right for closure.
So time gives a really structured way to assess and plan. The overall treatment goal is still relieving pressure, obviously, plus
Plus, creating the optimal conditions for the body to heal itself. That means keeping the wound moist, but not too wet, getting rid of any dead tissue, and controlling infection.
and the guidelines specifically say things like ultrasound therapy aren't recommended.
Right. There's just not enough strong evidence to support those kinds of biophysical treatments for pressure ulcers currently. Stick to the basics.
Okay, focusing on T tissue. If there's necrotic tissue, it needs to come out. Debridement. Sharp debridement with a scalpel or scissors is fastest.
It is, and it's usually preferred if you suspect infection to get rid of the source quickly. But you need to be careful.
Especially on the heel you mentioned.
Yes, particularly on the heel where blood supply can be poor. Sometimes it's better to wait until the dead tissue clearly separates before doing sharp debridement there. Alternatively, you can use enzymatic agents like collagenase ointments, which slowly help dissolve the dead tissue.
Okay, moving to M, moisture and dressings. The guidelines say no single dressing type is best overall.
Correct. The choice depends entirely on how much exudate the wound is producing.
So if it's really wet,
You need something absorbent. Think alginates or foam dressings. They soak up the excess moisture.
and if the wound is too dry,
Then you need something that donates moisture or keeps it in and doesn't stick. Things like hydrogels or simple paraffin gauze dressings. You have to tailor the dressing to the wound's current state, which might change.
let's tackle an infection. This is another area with some strong don'ts.
Yeah.
If you suspect a local infection, what's the first step?
First step is always to clean the wounds more thoroughly and debride any necrotic tissue as that harbors bacteria. You might consider something like a cadexome iodine dressing, but the evidence for it isn't super strong.
But here's the big caution.
Hmm.
What should we avoid putting directly in the wound?
Right, this is crucial. The guidelines strongly advise against using common local antiseptics. That includes things like chlorhexidine, hydrogen peroxide, even povidone iodine solution directly in the wound bed. Also, dressings containing silver or medical honey aren't generally recommended as first-line treatments.
Why avoid these? They kill bacteria, don't they?
They do kill bacteria, but they're also cytotoxic.
Meaning toxic to cells.
Exactly. They can kill or damage the very cells your body needs for healing the fibroblasts, making new tissue, the keratinocytes closing the skin. So you might be killing germs, but you're also hindering the repair process.
Okay, that's a really important takeaway.
Yeah.
So systemic antibiotics are only for
Only if there are clear signs the infection is spreading beyond the wound, like cellulitis, or systemic signs like fever, or feeling generally unwell, not for just a bit of local redness.
Finally, let's address pain. It's common, right? 50 to 75% of patients report it.
Yes, significant pain is very common with these wounds.
How do the guidelines suggest managing pain during dressing changes or debridement, which can be excruciating?
For that specific procedural pain, the recommendation is quite precise. Use a topical anesthetic cream, specifically lidocaine prelocaine cream. Apply it to the wound and surrounding skin. Cover it with an occlusive dressing for about 30 to 60 minutes before you do the procedure.
And that helps.
Yes, studies show it significantly reduces pain during care by about 2 points on a 10-point scale, which can make a big difference to the patient's experience.
Okay. What about the background pain, the continuous ache between procedures?
For that, the guidelines suggest considering ibuprofen foam dressings. These are special dressings designed to slowly release ibuprofen into the wound bed for ongoing pain relief.
But there's a catch, isn't there?
Yes, an important one. They need a moist, exudative wound environment to work properly. The moisture helps release the ibuprofen from the dressing. They won't work well on a very dry wound.
Understood. This has been incredibly clarifying. So the big picture.
Yeah.
Relentless prevention using that 30-degree positioning rule and obsessive heel care. And if a wound develops, use the time model for structured, targeted assessment and treatment.
That's the core message. Prevent, 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 and assess systematically using time.
And to leave our listeners with a final thought,
Yeah.
maybe something about the healing journey itself.
Right. Well, it's important to set realistic expectations. While a Category 2 ulcer might heal in, say, 50 days or so, the deeper Category 3 and 4 ulcers, they can take weeks, often many months, sometimes even longer, to close fully, easily. Healing time depends hugely on things we've discussed: nutrition, managing other health problems, effective pressure relief. Because it's such a long haul and progress can be slow, that's why consistent, objective measurement is vital. You need to track the length, width, depth, and tissue type regularly, maybe weekly. It's the only way to know if your plan is working over that long, difficult journey and to keep everyone motivated.
That focus on objective data, even when healing is slow, is really key. Excellent insights. Thanks for joining us for this deep dive.